the Ministry of Agriculture and Fisheries, the Ministry of Industry, Investment and Commerce, as well as the University of the West Indies for this collaboration yearly. Now, antimicrobial resistance occurs, as we know, when bacteria, viruses, fungi, and parasites resist the effects of medications, making our common infections very difficult to treat, and also increasing the risk of disease spread, severe illness, and even death. And so multiple factors, including overuse of medicines in humans, livestock, and agriculture, as well as poor access to clean water, sanitation, and hygiene, have accelerated the threat of antimicrobial resistance worldwide. And so this morning we have a very excellent lineup of speakers to just guide us through antimicrobial stewardship. And our first speaker is Dr. Pilar Ramon Pardo from the Pan American Health Organization. And he will take us through in an abled way on the topic, what is antimicrobial stewardship? And we'll also share PAHO's initiatives, their future plans for antimicrobial stewardship and the implementation in the various sectors. So let me use this opportunity to welcome everyone again and just to introduce to you our first speaker. So Dr. Pilar Ramon Pardo, MD, PhD, is the coordinator of the special program on antimicrobial resistance at the Pan American Health Organization, the WHO Regional Office for the Americas. After training as a specialist in internal medicine, she obtained her PhD from the Complutense University of Madrid with a thesis on antimicrobial resistance in Latin America. During the last 20 years, she has worked in prevention and control of infectious diseases in different countries in Africa, Asia, and the Americas. Currently, she is a coordinator and responsible for the planning, programming, and implementation of regional strategies to support Latin American and Caribbean countries in carrying out and scaling up national responses to antimicrobial resistance. So at this time, let us make way and welcome at this time our very distinguished speaker, Dr. Pilar Ramon Pardo. Let us just welcome her as she comes.
Okay, many thanks, Dr. Nelson, for this beautiful introduction. Thank you so much. It's really a pleasure being here with you. And let me try to share my, 1 second. So let me know if you can see my presentation now in this. Can you see that? Fantastic, fantastic. So let me start congratulating Jamaica for this fantastic program. I think it's the only country in the region of the Americas with activities every single day of the week. And this is a fantastic celebration of the World Antimicrobial Awareness Week in Jamaica. So thank you so much to the authorities for the commitment and dedication to organize and put together this fantastic program. So I think that today we are going to speak about antimicrobial stewardship, and let's start giving a panoramic of the topic. And for sure, let me just to clarify that I will be speaking specifically from the health sector with a multidisciplinary approach, but mainly health sector, because under One Health approach, we collaborate very closely with the PAHO, and you see Marisa Caipo is representing here the Food and Agriculture Organization of the United Nations, and as well with the OIE, is the organization, the World Organization for Animal Health. So the three organizations together, we join forces to strengthen antimicrobial stewardship all over One Health. But now we are going to just focus on human health. Okay, the presentation will have 3 sections. The first one, we will speak a little bit about the context and justification of the new WHO global policy on antimicrobial stewardship that you will see is quite comprehensive. So second section will be the AMS, antimicrobial stewardship global policy. And then we will finalize with the opportunities from the present to the future. So let's start with the context and justification. So of course, we cannot start speaking about public health nowadays without mentioning the COVID pandemic. not only at the global level, but as well the impact in the region of the Americas, with more than 95 million of cases and more than 2 million of cumulative deaths related to COVID pandemic. This is a very strong situation when the antibiotics have been really very broadly used and in some cases misused. So let's see and let's analyze how COVID pandemic has affected antimicrobial use. First, we have to notice that they are more or less the same profile of the patient. So the same profile for the COVID severe cases and the same profile for multi-drug resistant infections in the hospitals. So they are very vulnerable patients with underlying condition, hypertension, diabetes, obesity, and as well, they have multiple devices. They are under mechanical ventilation. They have central lines. So that was very relevant, especially at the beginning of the pandemic, when there was information about more than 50% of the COVID deaths were related to super or additional infections. So at the beginning of the pandemic as well, we saw that there was a very high antibiotic use, and it was higher than the reported incidence of secondary infection, between 10 and 50% of the patients. Another important situation, the hospitals, the intensive care units, they were really overloaded because of the increased number of COVID patients. So it has impact on healthcare-associated infection, has a breach on the infection prevention and control practice. And as well, if we look as well at the community settings, there was many clinical trials and very confusing information about the use of azithromycin, hydroxychloroquine, and or ivermectin. So everything that was confusing, and many of the prescribers were increasing the number of prescriptions and providing antibiotics to the patients. But soon we had some kind of evidence that was robust evidence coming from systematic reviews, and then we learned more or less the figures that we just mentioned. About 7-8% of the hospitalized patients having associated infections. Double of that number, 40% of these patients in intensive care units, they had the more severe patients with sepsis, hospital pneumonias, they were with infections. But, and as an average, 72% of the patients, that means 3 out of 4 patients, they were under broad spectrum antibiotics. So this is important, 2 messages here. There are 2 important messages here. The first one is the incidence of bacterial infection is low, is lower than influenza. And second, at that point of the pandemic, there were no intervention described for the appropriate use of antimicrobials. I said this information is from May 2020, but I would like to share with you more recent information. This is coming from the WHO Global Clinical Platform for COVID-19. So this is a global database with all the many countries, 37, they are providing clinical data from patients, more than 60,000 patients. And you will see the use of antibiotics is extremely high, even if the patient is under considered mild, moderate severity, severe or critical severity, or one that they are undefined severity because the data is not included in the database. So you see is almost 90% as average the use of antimicrobials in severe COVID-19 patients. But we know that there is as well some kind of interaction and impact of the infection in the COVID-19 patients. We have here the information from a secondary infection in COVID-19 patients. This is a prospective study that was carried out in Italy, and it shows that along the time of hospitalization, the proportion of infected patients increase along the time. And if the patient is more than 28 days in the hospital, which is extremely rare but can happen, the proportion of infection is almost 20%, can be up to 20%. So it's important to identify the patient that they are at higher risk of infection. This is the one that they have this kind of signal that they are severely infected with severe conditions, with and as well with the risk to be in ICUs, and try to identify these factors to provide the adequate treatment. But it's important not only the incidence of infection, but as well the relation to lethality. So in that series of cases, around 26% of the patient died, which is a high proportion, but we know that it was the lethality rate at the beginning of the pandemic. But if the patient has a secondary infection, almost 45%, so almost half of the probability for a fatal outcome. So this is important because then we know that antibiotics, they are needed and should be appropriated to the condition of the patient as well. Because of the increased use of antimicrobials, we are seeing in the region an increased number of resistant mechanisms. And that's why we issue a couple of alerts. We started with some alerts related to fungal infection, one multi-resistant fungal infection, Candida auris, later on mucormycosis, and later on as well, the last one was about the carbapenemas mechanism that they are now spreading in the region. So we were able to identify this emergency, and this emergency of new resistant mechanisms of this chain in the geographical distribute was because of the country they have the capacity to detect this kind of mechanism. And as well, we have signals from the Caribbean, so new countries that, or not new countries, countries where they were not before, carbapenemas, now they are starting to detect the mechanism. So this is important to recognize, and as well, this is a call for action about the appropriate use of antimicrobial. We need to decrease as much as possible the inappropriate use and as well provide the adequate treatment. We have as well some information from the National Action Plan. There is one survey that is every year, and it's a tripartite survey, and we have the data from 2020. And let me highlight a few data just to provide more context on the use of antimicrobials. So this is a question related to the monitoring the use or sale of antimicrobials, and there are several responses from A to E. And with A, it means that there is no specific system for monitoring the use of antimicrobials. And the E is that there is much information data, and the data is used. So you will see that the region, you will see that the global data information is in blue column, and the Americas is in orange. So you will see that in comparison, there is very important and very worrisome information about the lack of system to monitor the use of antimicrobials in the region of the America. This is a regional information. So there is something that we can strengthen, and we can as well foster the use of this kind of monitoring system of antimicrobials. But when we look at the different interventions that can reduce AMR in human health, the first one is about infection prevention and control. And this as well, this is important to know that once the resistant is there, the only way to contain is with adequate infection prevention and control practice. So in the region as well, in comparison, there is quite well development of the IPC programs along the hospital, you see here in the hospitals, in the health centers, but there is still something more to be done about the national coordination of these IPC programs. So programs are in place in many of the hospitals of the Americas, but we need to strengthen the capacity of coordination at the central level, at the Ministry of Health. Okay, so that is work in progress. And what about the programs or the policies to optimize the use of antimicrobials in human health? So as you see the same, the A is that means that there is no any intervention, and E that the intervention is implemented with monitoring and evaluation. And in the middle, C means that there are hospitals, healthcare facilities that they are implementing adequate programs to improve the use of antimicrobials. So here we are in a good position, but as well in comparison with the rest of the world, and we should be doing more to incorporate the stewardship programs at the central level of the countries. And if we look at the regulation, and here you will find some data about as well from One Health, approach. So you will see that the regulation about the sales and use of antimicrobials, they are present in the countries in the region. Here you will see in blue means is only data from America. Blue means yes, that the country has, no, that they don't have, and then the no is in gray. So you will see that the most of the countries in the region, more than 90%, they have laws and regulation on prescription and sale of antimicrobials for human use. But when we speak about growth promotion, we are in a very complex situation. There is less than 40% of the countries, they have laws or regulation that prohibit the antimicrobials for growth promotion. So this is something as well that we have to tackle from the One Health perspective. Let's now discuss about the antimicrobial stewardship global policy. And just to mention that this is a policy that was recently published a few months ago, with the purpose to respond to the demand of the member states and to provide guidance about how to implement comprehensive and integrate national antimicrobial stewardship activities. That is the purpose of the policy, of course, based on evidence. And the target audience of the policies, they are national policymakers at the Ministry of Health, national AMR coordinating bodies, and in general, the people, the teams that they are making decisions in public health at all levels. So this is the policy, the WHO policy guidance on integrated antimicrobial stewardship activities. You can access to the policy and get more information as you wish. And just to let you know that the process of development was very comprehensive. There was extensive consultation with experts. There was a global consultation meeting, and there was several rounds of comment that were received. And as well, at the end, when the document was approved, it was translated into all UN languages. So if we want to know exactly what we are talking about, the definition of antimicrobial stewardship is like the definition that we use in WHO is a coherent set of which promote the responsible and appropriate use of antimicrobials to help improve patient outcomes across the continuum of care. So you see, the main purpose is not antimicrobial resistance, to prevent antimicrobial resistance, but is to improve the quality of care. That is important as well, because with this kind of programs at the end, the patient will benefit from. So this is many different actions that they are related to responsible and appropriate use of antimicrobials. And as well, taking into account that this action should be complemented by different other factors that is the new thing in this policy, to prevent infection prevention and control, to prevent community-acquired infection, and as well to involve water sanitation and hygiene and immunization programs in this policy. So this is the integrated vision about the policy. It has like different pillars. We are going to go in a brief comment under each one. So this is the package of the different pillars. The first one is the coordination and guidelines. And that means that is under responsibility of the national authorities. They have the coordination and the guidelines using different tools to provide this kind of coordination and guidelines to the healthcare sector or to the hospitals. The second pillar is access and regulation. So this is important, not only have this kind of regulation laws that we saw already, that they are available in the region. They are the laws and regulation to limit the sales and the use of medicine, but as well, how we can change the behavior, how we can enforce the legislation. So there are a lot of discussion around that, and it's something that should be discussed as well at country level. The pillar 3 is about awareness, education, and trainings. It's exactly like this way that we are raising awareness on antimicrobial use, and we are promoting handling antimicrobials with care. Okay, education and training as well, they are basis for chain of behaviors. Pillar number 4 is about water and sanitation and infection prevention and control. So that means to prevent infection. That means that if the infection is prevented, we don't need to use antibiotic to cure the infection. So this is as well something that should be integrated in the antimicrobial stewardship policy. And the fifth pillar is surveillance and monitoring and evaluation. So it's important to know how much antibiotic is used in the country, how is used at the local level, and how we can as well monitor the trends. That is extremely important, for instance, to know exactly the increase of the use of antimicrobials related, for instance, to the COVID pandemic. There are some as well methodologies to help the countries to identify the use of antimicrobials at the hospital, but as well at the national level. And the last one is about the opportunities from the present to the future. So now we are looking at the future, we are looking to implementation consideration. We have seen that it's a very worrisome picture or perspective from the increased use of antimicrobials, the increase of resistance. So what can we do? How we can implement the policy? So there are several toolkits and manuals that were already available, and they are at your disposal. They are toolkits for implementing in healthcare settings, and as well the other manual from PAHO is for policymakers. Both of them, they are available, and you can look at those and learn specific activities or strategies that can be implemented. But when we speak about the policy, we were having a lot of global discussion. It was a discussion at global level, and WHO decided to organize regional workshop. We organized 2 in the region of the Americas. I know that Jamaica participated in the workshop for the English-speaking Caribbean countries. Was a lot of analysis and discussion on the policy, and as a result of this consultation, we had this proposed roadmap for the implementation of the WHO global policy, but adapted to the context of Latin America and the Caribbean, with several steps that were defined during the consultation. This is as well is available in the website, and we are very grateful to the countries that participate and provide their comments to develop this roadmap for the implementation. So just to finalize, there are several messages for you. So we are now looking at globally, but as well in the region of the Americas, an increased emergence of AMR because of the use of antimicrobials related to COVID. We are looking as well, we are seeing an increased transmission of antimicrobial resistance because we are seeing a problem, a breach in the infection control practice, and as well we are having an increased number of outbreaks, mostly gram-negative pathogens. And as well, we are seeing an increase in the disease burden related to AMR. Probably the lethality of COVID as well is related to AMR, to multi-drug resistant pathogens. So we are seeing an increase of mortality and length of stay in the hospitals. So this is an opportunity to highlight the importance of the detection and containment of AMR from the public health. And I would like just to finalize with the relevance of the World Antimicrobial Awareness Week 2020, spread awareness, stop resistance, and there are several. We started with the press conference of the PAHO director, Dr. Carissa Etienne, on September 17, and she was highlighting the relevance of the appropriate use of antimicrobials. And as well, because the Go Blue campaign, we have in Rio de Janeiro, this kind of beautiful images with the blue stadium and the blue illumination. So I will finalize with the words of Dr. Carissa Etienne. All healthcare professionals should use antimicrobial responsibly and prescribe antibiotics only when necessary. The misuse of these drugs is harmful to patients and also to public health. So thank you so much for your attention. Over to you, Dr. Nelson.
Okay, thank you so very much, Dr. Pilar Monparo, for this informative presentation. And for those of you just joining us, the focus for today is how does antimicrobial stewardship help to solve the problem of antimicrobial abuse and the threat of resistance. And we really want to thank Dr. Pilar Ramon Pardo for this excellent presentation. As we know, in the COVID-19 pandemic, there has been the misuse of antibiotics widespread, and this could lead to accelerated emergence and spread of antimicrobial resistance. I want to welcome those of you who are just joining us and you're up for a treat today. And so just to keep in the time that we have available, I will use this opportunity to welcome our second speaker, Dr. Karen Shaw from the Ministry of Health and Wellness. Now, at the end of all the presentations, you are free as of now just to type your questions at the bottom of your screen, and we will take all your questions at the end. So Dr. Karen Shaw, she will speak on the history of antimicrobial resistance and the antibiotic pipelines that we have. Dr. Karen Shaw is a consultant, clinical microbiologist, who currently serves the Ministry of Health and Wellness as Director, Health System Support, and Monitoring. And this she has been doing since May 2021. She has also served as a Director, Technical Support in the periods 2018 to 2021. Now, Dr. Shaw has been integral in the fight against COVID-19 in Jamaica, serving tirelessly since the first case was identified on our shores. So let us welcome at this time Dr. Karen Shaw, and she will take us through our second presentation.
Morning, Dr. Nelson. Thank you. Morning, everyone. I don't know if you are seeing my screen. Yes, tell me if you're seeing my screen.
Yes, we are.
Yes, all right. So thank you again. The discussion is really around the antibiotic pipeline, and it's always important to note, what is happening with regards to this, discussion, because we know the end result about having these agents available to us utilizing them, and of course the effects of it. But we should also pay attention to the back of the argument. So the modern age of therapeutics, was launched in 1930, and it started with the creation of the sulfonamides. And if you progress at least 10 years later, you had that eureka moment when they identified the drug that we know as the magic bullet called penicillin. Now, these drugs, along with many of its derivatives, they've played a very important part in decreasing, the effects of disease in terms of the morbidity and cutting down mortality of a number of infectious diseases. And since the 1990s, new antibiotic development really has fallen sharply. And therefore, we appreciate that while we have, failed to create new moieties, bacterial resistance continues to increase. And it should be said that in less than 20 years, it took less than 20 years for bacteria to show signs of resistance. So this is the pictorial that shows the spectrum, the continuum of the pipeline. It starts from about the 1900s when we, started to identify, and go through the various bacteria, and analyze them. And we see that in, as I said, the 1930s, you have the introduction of the sulfonamides and penicillin. But what you need to, what should catch your eyes when we start talking about the resistance? We see that there is a resistance shortly after the development of the sulfonamides around the 1930s. After finding penicillin, there was another eureka moment, if you want to say, where there was a resistance to penicillin that was identified. And it continues. There was a bloom, which we call the golden age of antibiotics around 1950s, 1960s, where there was a development of a number of agents and derivatives. And this would have been beneficial to human health, animal health, in that there were many choices. But as you go along, what you'll find is that we start to find organisms such as the MRSA, methicillin-resistant Staph aureus, being detected in the 1960s. Plasmids being 2 sulfonamides now being detected, and plasmids, the bacteria can share these plasmids quite easily, and therefore we are picking up on the mechanisms now of resistance as we go along. In the 1980s, there was the introduction of the carbapenems. We have also in that same period where we identified the first vancomycin-resistant Enterococcus. So the pipeline comes to an end abruptly. If you think about it, we are in 2021 where we have so many things available to us in terms of technology, and information. And yet still there's not the mechanism for the development of antibiotics or antimicrobials has pretty much, run dry. When we look at the antibiotic classes that we have available to us, there they are on the left, the aminoglycosides, the cephalosporins, etc. We know that they can be used to treat organisms both in the gram-positive category, so your staph, your strep, and of course, a lot of those were made for the treatment of the gram-negative, so your E. coli, your Klebsiella, as common examples. And you can see the impact on the far right of, the introduction of these classes. We've used it to treat everything. So we know the benefits of having these antibiotics available to us. When you look on the scale of the types of organisms, as I said, you can see as the moieties were developed, their sort of, their capacity or the number of organisms to which they can cover sort of got larger and larger. You can see right in the center there, ciprofloxacin can go from, granted that you have to get some guidance from the lab. The discussion is that, with the spectrum of coverage, mostly for gram negatives, but it does have some, GPC coverage. So the take-home message is that we've had an opportunity in that we've created a number of antibiotics. The benefits are known. We have shared this information with our veterinary counterparts. So a lot of the antibiotics that are helpful to human health are also helpful to animal health. So there are very few of them that are only for human medicine. And that is the carbapenems and, your meranem, and of course, your glycopeptides. You'll be thinking about things like your vancomycin. So drug resistance, as we know, is it's either acquired or a naturally occurring phenomenon. We know that it's unstoppable. What we try to discuss here by implementing all of these methods is really to mitigate, to slow down the process, because we recognize that the microbes, they are going to continue to develop resistance. We just want to slow the process. So it is generally slow. That's resistance is generally slow. It can be reversible if you catch it early, and it depends on the mechanism of resistance. You can reverse it, or it can be irreversible. And you can accelerate the process though. And this is why we discuss antimicrobial stewardship as a critical entity. You also have the supporting structures in terms of the regulatory, as Dr. Pardo had just discussed. We want to, minimize the inappropriate use of antimicrobials. And then you also want to look at the discussions of compliance, because these are the things that tend to push resistance. And you have to also look at your partners. As I said, these antibiotics have value not only in human health, but you have to think about plant, animal, food safety, and the environment. So typically this discussion of antimicrobial resistance is almost akin to an iceberg. We see the bugs coming out, and these are the microbes that are super resistant, and they're just the end process of what may be hidden. the issues within systems. So you're talking about accumulation of resistance to multiple antibiotics, self-medication and poor compliance, inappropriate use of antibiotics in terms of selection and multiplication of resistant strains. Sometimes we go very broad spectrum, with a heavy hammer, and you clear out all the helpful commensals, and therefore you leave behind the resistant strains. And then you have to add to it now the gaps where there may be weak surveillance and regulatory systems and the continuous natural evolution of these microbes. So it's an iceberg phenomenon. So what it says is that, we've gone through, as I said, we had our eureka moment, we went into full bloom, but what has happened, so we're coming from the dark ages, and what it seems to be is that we are going back into the dark ages. And therefore, the WHO, raised the alarm in terms of saying that, the antibiotic resistance is a major global threat. So we look further at the guidance that has been put forward from WHO regarding the preservation of these agents. Now we know that there is full support for optimization of the antimicrobial agents in human and animal health. And this is really to preserve effectiveness by taking a One Health approach. So we are in full agreement that, there has to be a joining together of all of the players, the stakeholders. There are some general recommendations, and I will go through those. And then there are some specific recommendations. And these specific recommendations really are looking at, some restrictions. Most of them were put towards animal health in order to assist in the preservation of vital agents. And therefore they have categorized, all important antimicrobials into 3 groups. They're talking about the critically important, the highly important, and the important. So in the overall recommendations, and this is applicable to both all the stakeholders, is that you have to start with governance. The discussions of the National Action Plan and the National Alliances against AMR are critical. You want to have your designated focal points that have these programs as their single portfolio, or you can look at the constitution of a national body where there's representation, to discuss these matters, and then there will be information sharing. And then what that filters down into now is the development of a regulatory body or a standard. So we look at the development of an application of a standard treatment guidelines in health and in veterinary sectors. You discourage the non-therapeutic use of drugs in animals. You have restrictions for the OTC sale of antimicrobial agents. Along the lines now, we get the development of the various SOPs and documents, and the critical component is the creation of a surveillance program. And the surveillance program is not just to detect the antimicrobial resistance, but it is also important to monitor the use. How are we using these agents? So you have training of your prescribers for the rational use of antimicrobials, reducing the disease burden. Of course, the ever critical discussion of infection control, and you have the need for undertaking operational research. Lastly, the recommendation speaks to now reaching out to the community on a wider scale, and therefore educating your end users as to the accepted regimes for treatment, and encouraging adherence, and therefore you would discourage self-prescription. So what does that sort of look like in terms of the standard treatment guidelines? So we just have a look at the regulatory. I mean, at current, there's discussion for access, watch, and reserve. So some drugs, antimicrobials or antibiotics, have been placed on a sort of green light, amber, and a red sort of stoplight mechanism. So some medications can be accessed freely without discussions and supervision. And we're not saying that you go ahead and we would still like to see culture directed. I think that the laboratory plays a very important part in the discussion. And therefore, these drugs are accessible within the context of the patient, being thoroughly investigated. And then there are two other categories, your amber light, which is your watch. So certain medications and antibiotics are placed in this group as a matter of you are limiting the use, so it is not widespread use, and therefore you should really have it be culture directed. So you're looking at your Zosyn, your meropenem, your cephalosporins, of course, azithromycin. And currently we are in a bit of a battle because the azithromycin has gained a lot of popularity, in the treatment, the discussions of the treatment of COVID. So having that, it being placed on the watch list is a bit of a challenge. Then you have antibiotics that fall in the reserve, and therefore these antibiotics are usually kept for patients that are severe, where it's almost a risk benefit discussion. So you don't have them readily available for use, and therefore we preserve these agents. Some of the other programs to which need to be or serve as the guidance in terms of the surveillance, well, you have the discussion of the integrated surveillance for foodborne bacteria. Because of that intimate relationship between, human health and animal health, and the transfer through food producing animals, you definitely have to have a program that looks at the surveillance of antimicrobial resistance in animals, in humans and food, and of course the use of antimicrobials in all populations. And then the last surveillance entity would be the discussions of ESBLs. So the extended spectrum beta-lactamase producing E. coli is something that they've been looking at and putting forward, where you're going to be surveilling for humans along the food chain and the environment. So specific recommendations. Well, the WHO had given a list of critically important antimicrobials. And this is because they looked at the resistance along the food chain. And what they did was basically divide these agents into critically important, highly important, and important. Now, the critically important can be further divided into highest priority and high priority. So what does it translate to? So some specific recommendations, and this is speaking to use in animal health. So this group is further divided, as I said, into highest priority and high priority. So the highest priority, and those are usually your cephalosporins, your glycopeptides, your macrolides, your polymyxins, and your quinolones. So Cipro, your roquefins, those sorts of medications are not to be used in animal health for growth promotion, prophylaxis, control use. And of course, it's not to be used for treatment unless it is the only choice. So this was something that was put forward as a recommendation for the critically important antimicrobials. For those entities that fall into high priority, you're looking at your aminoglycosides, your carbapenems, your monobactams, your penicillins. These they're not to be used for growth promotion. They're not to be used for prophylaxis. They're not to be used for control use, but they can be used for treatment. The third category is really the highly important, and then highly important now speaks to your cephalosporins. I think I'm repeating a slide. No, highly important, right? So your penicillins, your streptograms, your sulfonamides, they're not to be used for growth promotion, prophylaxis, but they can be used to treat once the disease state is confirmed. So your tetracyclines also fall into this group. So you'd have to take the culture from the animal, show that the tetracycline is required, and therefore you could go ahead and utilize tetracycline. And then the last one would be recommendations for the important group, where you are looking, it should not be used for growth promotion, prophylaxis, but it can be used to treat the disease once the disease is confirmed. And these examples are usually your cyclosporin, for example, or your colistin, your bacitracin, metronidazole, your streptomycin, and your neomycin. So this is what the table looks like. And as I said, these are specific recommendations. So what we're trying to do is minimize the use of these classes of antibiotics in the management of animal health. We are reserving them for human health. So in summary, we know that the modern age of therapeutics was launched in the 30s, and we're very grateful. You know, these drugs, as we said, have played an important part. And, you know, it helped to, you know, cause a dramatic decrease in the morbidity and the mortality of infectious agents. But since then, the pipeline has pretty much run dry. And it is in a context in which we understand that bacterial resistance is still increasing. So the problem, you know, while we saw help and a light at the end of the tunnel, we have started a chain that we need to continue. So in order for us to slow the process of bacterial resistance and to preserve the agents that we have, the medications that we have to, you know, agree that a One Health approach to AMR may be the only comprehensive way in which we can look to preserve the medications that we have today. Thank you.
Thank you so very much, Dr. Shaw. I told you she would definitely be able to help us and remind us that, you know, even though drug resistance is unstoppable, there are things that we can do to minimize the occurrence. And here we're promoting and highlighting the importance of the One Health approach. Again, if there are those of you who are just joining us, welcome again. And we will at this time just welcome our third speaker, our University of the West Indies representative, well-known speaker, public speaker, a force to be reckoned with when we talk about antimicrobial stewardship. And that's no other than Dr. Alison Nicholson, former head of department of the Department of Microbiology. And she will be presenting preserving antimicrobials by stewardship, implementation of antimicrobial stewardship in human health. Now, let me just use this opportunity to introduce to you, for those of you who do not know her, Dr. Alison Nicholson is a senior lecturer in the Department of Microbiology at the University of the West Indies, Mona. She's also consultant medical microbiologist at the University Hospital of the West Indies. She chairs the Infection Prevention Control at the University Hospital of the West Indies, and she is a member of the Jamaica Antimicrobial Resistance Working Group. Her special interests are in antimicrobial resistance and infection prevention and control. And so she's very qualified to speak to us on preserving antimicrobials by stewardship. Let us welcome at this time Dr. Alison Nicholson. Remember, you can post your questions at the end, and we will take all the questions after. Dr. Nicholson.
Not sure what's happening here. Oh, I know what's happening. Sorry. Okay. Hey, good morning, everyone. Good morning, Madam Chair, Just
Morning,
need a-
Dr. Lee.
just give me a minute to sort my screen out, please.
Sure, no problem.
Dr. Nelson, are you seeing my presentation now?
No, we're not seeing the shared screen. Do you want to take the next speaker before you, or?
Are you
Yes,
seeing
it's coming
now?
up. Yes, it's coming up. Just go to
Okay.
present slideshow.
Okay, thank you.
Okay. Excellent.
Okay, good morning again, everyone, and my apologies for the delay. So this morning, I'm going to be talking to you on antimicrobial stewardship, and the speakers before have addressed this topic in a fulsome way. So I'm not sure how much I'll be able to add, but at least I am sure going to try to add the perspective of somebody in a developing country. So let's see how we go from here. The concept of antimicrobial stewardship has taken center stage in recent times, and not so recent actually. And that is all in response to the threat of antimicrobial resistance. When you couple this threat with the fact that there's a decreased production of new drugs, then you realize that antimicrobial resistance poses a serious existential threat. When you consider also that the alternatives to antibiotics are still a long way off, there are examples like gene silencers. Some have been identified and work is being done with that, but it's still a long way off. And then you have your bacteriophages. Of course, this is being used in some countries quite a bit, but it's not something that is, that the international community has embraced as yet. So just to give an overview, this picture has been painted already, but I think it bears repetition. The thought that by 2050, antimicrobial resistance could result in 10 million deaths and could cost like $100 trillion US. I'm not sure how many of us can even imagine what $100 trillion US would look like. This is just presenting the same information in another way. So what happened? What on earth happened here? How did this happen? And I'm going to ask you as you listen to me, just tick the boxes. If this belongs to you, you can say tick. If it doesn't belong to you, you can pat yourself on the shoulder and say, not me. So how did this happen? Overuse of antibiotics, tick. Not enough regulations in some places, no guidelines, no antibiotic guidelines, antimicrobial guidelines, no extra training of doctors to deal with the emergence of resistance. So the minimal training that you got in antimicrobial resistance during med school is now required to serve you at a time when, as I've said before, we are facing these enormous odds in the area of antimicrobial resistance. No extra training of the public to deal with the emergence of resistance, because surely they are a part of the solution as well. What about the use of antibiotics in animals and plants and the environment? If you're like me, I had no idea that these sources were actually, were also promoting antimicrobial resistance. I kind of thought foolishly that this was the domain of the human health sector, until I began some years ago to delve a little deeper to realize that no, it's a shared responsibility, and that is why the One Health approach is so important. What about regulation of antimicrobial usage? There are some countries within the Caribbean where you can get antibiotics and it's not against any kind of regulation. So you can imagine what happens if you take your neighbor's medication and take it to the pharmacy and said, can I have some of this? And it's levofloxacin or some other antimicrobial agent that you would prefer not to use as a first-line treatment. Then the discipline of infection prevention and control. Remember that that discipline has basically exploded since about the 2020. At the beginning of the 21st century, sorry. Prior to that, yes, we know that Ignaz Semmelweis had made his big discovery in about 1846, but the impact of that certainly was not felt as it should have been felt. And it really took a lot more effort to actually propel the discipline of infection prevention and control center stage. And the truth is, antimicrobial resistance is one of those things that played a role in propelling it to center stage as well. So in some places, in some countries, and in some hospitals within some countries, what is the role of infection prevention control? Are there practitioners there? Do they have guidelines? Are they being followed? What about supplies in order to comply with these guidelines? Simple one, hand hygiene, how is that monitored, et cetera, et cetera. So in the absence of these, then the things that facilitate antimicrobial resistance and its spread will continue to flourish. Pharmaceutical companies also, do they share any responsibility in this? Could they have sounded the alarm earlier? They were the ones who were noticing that their profits weren't as great because of an antibiotic losing its efficacy after a certain period of time. I'm not trying to blame them. I'm just trying to shine the light a little bit and spread the responsibility around to say that we all played a part in this situation that we are now in. So as I said before, the definition of antimicrobial stewardship, a coordinated set of events to improve and measure the appropriate use of antimicrobials by promoting the selection of the optimal drug regime, correct dosage, correct duration of therapy, and the correct route of administration. And of all the antimicrobials that we have to think about, because the antimicrobials would be a collective term for your drugs against parasites, viruses, fungi, and bacteria. But I want to posit that perhaps the agents, the antibiotics, are perhaps the greatest challenge at this point in time. Now, Alexander, the success of many of the advances that we now have in medicine is predicated on the availability of antibiotics. And we have to thank Alexander Fleming and company and many others along the way who have contributed in that way. Things like transplant surgery, the use of prostheses, orthopedic, cardiac, etc., chemotherapy for malignancies. These have a certain effect on the patient, makes the patient more vulnerable to infections, and therefore the presence of antibiotics would take care of that and then allow the procedures to be successful. When you lose antibiotics, you're going to be wiping that out. So we're assuming that if you have a good antimicrobial stewardship program, then you will have improved antibiotic prescribing practices. So this would optimize antibiotic use across all sectors. Then this would protect patients from unnecessary antibiotic usage, that's patient safety. Clinical outcomes would be better, healthcare costs would decrease, no prescribing of antibiotics willy-nilly, unnecessarily, etc. And you would, of course, minimize harm by reducing antimicrobial resistance. Now, I decided that that sounds good and easy to monitor, but those of us on the ground know that it's definitely not as good. So I thought that, maybe the definition of antimicrobial stewardship is far more complex than the previous one. So I decided to try it myself, and I came up with this. Antimicrobial stewardship is a sophisticated machinery made up of many moving parts, with each one designed to complement the other for maximal effect in the deterrence of antimicrobial resistance. So it's not do one and you get A, do two and you get B. It's really many moving parts that have to be working together with a certain synergy, a certain understanding of the importance that each part plays, and understanding that if this part doesn't do its work and I run in to do mine, I'm going to go in at a loss. So it requires all hands on deck. So now I want us to take a little look at some of the moving parts. And these are some of the things that would be useful in implementation of your antimicrobial stewardship program. You need to get hospital leadership commitment. Since I've been working in infection prevention and control, I have understood the value of getting leadership buy-in. And I will say, certainly for my hospital, and I'm sure many of you can say that for your hospital, if you can speak to top leadership and get them to buy into what you're doing, it's amazing what will happen. And I could tell you some examples, but I don't want to reduce it to that. I just want to say that try to get hospital leadership commitment. Now, how does that work? Sometimes you have to make an appointment to sit with leadership, and you have to do this on a regular basis as needed, so that leadership can begin to get a sense of your passion, a feel of why it is that you need to come back for more funding to do X, Y, Z, an understanding of why this particular machine will work. And I've shared this before, but I'm going to share it again. I remember thinking that us having a particular machine in the microbiology lab would help in rapid diagnosis, rapid identification of microbes, which would of course have implications in the management. And what I did was to speak to one of my colleagues who actually had one of these machines. And I know he had to do a lot of research as well in order to get the machine. And he was coming to Jamaica to do some work in our department. So I asked him, please walk with your presentation. I want an opportunity for you to speak to my CEO, operations manager, etc. And he did. We had a meeting with the CEO, with the operations manager. And by the time we were finished, he said, I want one of that. And that was it. We now have that machine up and running, and the staff, the members of staff are loving it because of how quick and easy it is to work with. Very expensive to buy, but the reagents are fairly cheap. So we will get back our money and then measure the cost of that in terms of infections, morbidity, mortality, etc. So you have to take the bull by the horn, as it were, meet with the leadership and get their buy-in, get their commitment to support you. And this support shows itself in many different ways. For example, they now can put pressure on the HODs, on the heads of departments, on different consultants, on different aspects of the hospital. And they, in throwing their support behind you, in your antimicrobial stewardship program or in your infection prevention control program. And you've heard already that these two interlock, they work together, they're complementary. And if you can get top leadership to buy into that, it will make your job a lot easier. The persons you have to interface with know that they're not just interfacing with you, but they're interfacing with you backed up by top leadership. So it is worth whatever it takes to have this one-on-one meeting on a regular basis so they understand where you're going. Don't let them find out about your challenges from the news or outside. You go, FaceTime, explain to them, tell them what can be done to head off this challenge, to interrupt this particular pattern and see what happens. So your hospital leadership, as I said before, can rally the pharmacists, the people in microbiology, etc. But after you've done that, there needs to be somebody to do that, who will bell the cat, as it were. So if you don't yet have a leader who can stand up and represent you, represent management to you, then you need to select such a person because there needs to be accountability. If you don't have somebody standing there, there won't be any accountability. So when things don't get done, you look around, who is to be blamed? We don't really know. But if you have a leader, then there's that person who will then have to take the responsibility. Remember too that you need to have action. You need to implement interventions. You need to then provide feedback. Having the intervention alone won't work. You need to be able to say, we did this and this happened. When you provide feedback, it's amazing to see persons' response. For example, you will say, look, the multi-drug resistant organisms spreading in a unit, they are expensive because they're multi-drug resistant. So you have to go to top antibiotics. It will cost you more, etc. Can you give me a particular piece of equipment, because the staff in moving around from bed to bed, for example, they might be, do committer, can I get one because I'm having one for the entire, say, intensive care unit, to be dramatic. And so by the time I move that from bed 1 to bed 2, I don't know what's happening by the time I reach to bed 14. I've tracked my multi-drug resistant Acinetobacter through the intensive care unit. One machine is not enough. Now, you might have been saying that for years, and after a while you said, you know, I can't be bothered. So I want to tell you again of another instance where we had an outbreak of multi-drug resistant Acinetobacter in a particular unit, and we were able to break down what was happening. But more, a study was done by two of our interns. Actually, they were rotating with us, and we gave them that study to do, monitor them, help them, and they did a great job. And so we were able to say to management, look, we had an outbreak of Acinetobacter in this particular unit, and it lasted X time. It involved 9 patients, and it cost us $4 million in addition to the patient's cost for being in hospital. This was an additional $4 million. Now that makes people sit up. In no time, we got our extra machines. Now, yes, did it have to be like that? I don't know, but the fact is, now we know. So when there's a problem, don't be at the moon, get some data and present that data to key opinion leaders, to people who can make decisions, who can make changes. It's a lot of work, and sometimes you need help. But if you're going to take on the position and you're going to be rallying the troops, these are some of the things that you have to do. So action is important. That's one of those are some of the actions that I've mentioned. Guidelines are important. You need to have guidelines that are working, and we are a work in progress where that is concerned. Sometimes we will bring the guidelines up to a certain point, and then there's a glitch, and then we have to go back over, start again. And so it's sometimes hard to get that running seamlessly, but we press on and we keep trying. Feedback is important. As I said before, if you're implementing something and it's working, then you need to give feedback so persons can understand. If you encounter a particular problem, you need to give feedback as well. Pharmacy expertise is absolutely essential if you're going to have an antimicrobial stewardship program. So you have to become best friends with your pharmacists. They have pharmacists, they have to buy in, and most of them are very aware and very willing to partner with other persons in order to get this problem over with. And so getting in touch with your pharmacy team and making sure that you're working together, you understand each other. So if you're going to implement an IV to PO switch, the pharmacist is on board, they will play their part, they will alert the doctors, this patient has been on the ward and has been on IV antibiotics, would you consider doing a PO switch now, and probably giving some more details. That works. And we have tried it at our hospital. We have a form that we made up, I'll show you in a little while. And yes, you have to be careful not to appear to be giving instructions, but we can manage that. You do it in a way that's collegiate, and you said, this is, I was thinking, or would you consider? Persons are usually open to that approach. Also, it's important to track your programs. If this is what you're doing, you have an antimicrobial stewardship program. Can you track drug usage? Can you track costs? Are you able to put that again in data that will convince others coming on? So providing feedback to all concerned is important. Some feedback will mean more to other persons, but at some point your feedback hopefully will get to all persons involved. Education, no, that is ongoing, and most of us in our institutions, I believe, will try education at one point. And notice I said try, because you will feel something is happening and you say, I need to tell these persons about it, and you organize a seminar here and you organize a session there, but it's not continuous. It's not something that is institutional. It's just a thing that you try every so often. Sometimes you need to give it some thought and see how you can develop this kind of educational program. However, the studies have shown that education on its own doesn't really work as well as you think it should. So you put a lot of energy and effort and passion into providing these training sessions, and people come and they're always saying, oh, this was good, this was so good. But then what happens after that? And what about even your infection control team? You might spend time training and you all share, but what happens afterwards? And it's thought that you have to pair education with intervention. You measure the outcomes and persons can actually see, okay, so I've always done this 1, 2, 3, 4, 5, and I've never noticed that when I do that, the infection rate is 60%. But then I heard at this session that you should no longer do 1 and you should no longer do 4, and the order is incorrect. Let me try that. And then you try that and the infection rate goes down to 5%, dramatic. But yes, what can I say? Persons then will buy in, and then they will become your next evangelists, spreading the word on the value of these interventions. It's important that we're working as a team. No one person can serve multiple roles. One person can serve multiple roles, but no matter how many roles you play, you can't do all the roles. And it's important for you not to do all the roles. 1, you will burn out in no time. And 2, you will probably roll the stone up the hill, and the minute you stop playing your role, the stone rolls right back down the hill. So it's important to involve other members of the team. Identify your team and involve persons and assign roles or share what the roles are and allow persons to tell you where they see themselves fitting and how they think they could best help. That, I think, is probably the best thing. Also, be aware of the tools that are provided. It's amazing the amount of tools that have been provided for us out there. CDC, WHO, IDSA, SHE, they're providing as much support as they can. They have gone and done the heavy lifting. And what we need to do now is to just benefit from the heavy lifting and see how we can implement. We don't have to reinvent the wheel. Yes, sometimes we will take something that is said and we have to modify it for our situation, but that's different from designing it and constructing it all on our own. So the minimum requirements for your program then is you want a multidisciplinary team. It's not just for the infection control team. It's not just for the antimicrobial stewardship team. If it just consists of an ID physician and a microbiologist, or an ID physician and a pharmacist, you need more than that for your antimicrobial stewardship program. You need a multidisciplinary interprofessional team, usually directed by a physician, but not always. If there is somebody else who can play this role, especially in a resource limited setting, there may be somebody else who can play this role. In some cases, you may not have an ID physician in your hospital. You may also have an ID physician, but the person it's the only one and they're doing everything else, and so may not want to take the leadership role. So be flexible where that is concerned in our resource limited setting. Know the ideal, but remember, you may not be able to to operate based on the ideal all the time. So your team then should include a physician. You should have a physician. If you should have a clinical microbiologist. And as I say this, I know that many hospitals in Jamaica and across the region do not have clinical microbiologists. But I would use this opportunity to make a push, to make a plug here and to say to the powers that be, we need more clinical microbiologists. We are training them at the UHWI. We can bargain with you. You can send your doctor to join the program. We can train them, send them back to you. And we do have persons who are now trained and in the waiting room, as it were. We have a good program, and I think persons there would agree with that. It's not perfect, but at the end of the day, you know far more about microbiology than you ever knew before. And more than anything else, I would like to think that the persons who pass through our program leave with a passion for antimicrobial stewardship and for the role of microbiology in the region. So if any of the powers that be are, if anybody is listening to this, I would suggest that persons in government, persons who can make the decision, need to review the way you view the role of the clinical microbiologist and how important it is to have microbiologists in your hospitals across the country. We're no longer a clinical microbiologist doesn't just stay in the lab. The clinical part is put there for a reason. And so we play a vital role in things like your antimicrobial stewardship program and sometimes even with your infection control programs. So you need somebody from infection control, whether it be the doctor or an infection control preventionist. And of course, you must have your pharmacist. This is like your minimum team that you would need. Institutional guidelines are available, as I said before, for common infections. And should we legislate antimicrobial stewardship programs? I'm not aware that that is happening now, and I don't think that we are near there yet, but I am sure that persons who do this can testify to the fact that this puts teeth into the regulations that we're trying to implement. So this is your antimicrobial stewardship dream team. And I've basically said it already. I didn't mention having somebody from administration. And the truth is somebody from administration might not be able to commit to coming to your meetings, but you want somebody who you know understands what you're doing and will view your suggestions with some kind of interest, and when persuaded, will push your requests so that you can get what you need. I can testify that that works, and we've seen many examples of that in our hospital in a relatively short period of time. So when you look at this team, not all of us have these persons here in the Caribbean. So we work with the persons that we have, and I believe that we have enough persons from the different disciplines to be able to make a difference in the management of our antimicrobials as we face the challenge of diminishing agents. So reviewing antimicrobial usage at the UW, I'm just going to share a few snippets with you. We have a policy that says, well, it was introduced some time ago. It's not one that the doctors embrace, I can tell you that. So for my physician friends in the audience, yes, it's not one that the doctors embrace. It says here, in very serious infections, the approach is often thought that you hit hard and you hit fast after you've taken specimens for culture and sensitivity. So a patient who is critically ill, you want to give them a relatively powerful antimicrobial antibiotic combination for your bacterial infection. And you want to do that fast, but you want to take your specimens for culture first so that you don't confuse the results. But then it says, after you get back the culture results, then you need to de-escalate. So a patient is very ill, you think the patient is septic, you send blood for culture, you start with meronym and amikacin, for example. Culture results come back saying that the patient has 4 or 4 bottles growing enterococcus sensitive to augmentin. Ha! And many of our doctors will tell you, if it ain't broke, don't fix it. My patient is doing very well on meronym and vancomycin, thank you very much. I'm pretty sure that that has changed with time because we've had many discussions, and of course, persons have come to understand the implications. So I think persons are a little more open, but it still is like a step of faith to make that de-escalation step. But the truth is, if you're not going to de-escalate, then you really shouldn't be using the high-powered antibiotics like that. So a study was done in published in 2010 by ICU staff, doctors here I'm seeing. And the de-escalation, they found that de-escalation of empiric therapy was practiced in only 7.7% of cases where it was possible. So now you understand where we would hemorrhage some of our antibiotics. Now, prophylaxis, we know that generally speaking, that should be limited to a 24-hour period. A study again showed that the appropriate use of prophylactic antibiotics with discontinuation within 24 hours occurred in only 11.1% of cases. All right, I think that speaks for itself, very eloquent. So, and in another look at this, it showed that the duration of prophylactic in quotes, antibiotics ranged from 1 to 15 days. Now, would you regard this as low-hanging fruit? if you're doing antimicrobial stewardship, are you're like a bulldog, you want to just go in and eat this up, kind of thing, because this is something that you should be able to bring in a team, move through the different areas and address to see how you can get better compliance in this area. Now, as I said before, as you delve deeper into antimicrobial stewardship, you have help in the form of implementation strategies. And that is you actually have checklists that tell you, you don't have to now go through and now devise your own checklist. The checklist is there, will help you to perform your gap analysis. And again, this is provided by several of the organizations that we mentioned before. So after you've done your gap analysis, you know your current landscape, you know where the weak spots are, and you know where to place your emphasis. While you're doing general work, you have a better idea of where to place your emphasis. You can assess management support. And for us, again, in the Caribbean, information technology is not where it should be. And we suffer from that because what takes, for example, our study that we had our 2 interns doing on the cost of a small Acinetobacter outbreak took them quite a bit of time, and they were very diligent. I'll always remember those 2 because of the work they did there. But can you imagine, they couldn't use, you don't have records on the computer in a lot of situations. They had to go through all the data painstakingly in some cases, but they did it. Now, if you had staff and we do have computerization now, but there are certain other aspects that we need in order to be able to flow from one system to the other. We wait for that and we expect to have that very soon. But in other places across the island, where are they? Where are we where that is concerned? How soon will we be able to link with an area in a rural area and bring some light to bear on some of these issues that we are having? It's difficult, and it's difficult for all of us. In first world countries, that problem is not as bad because they have a lot of the equipment that we dream about that can make some of these assessments so much easier. However, I'm not going to give us an excuse for not doing them because we have gathered information that has been useful, and therefore, whereas it might be a little more difficult, it can be done. And more than it can be done, it must be done because antimicrobial resistance is not taking a back seat and it's not playing shy. So as long as it advances, there must be those who will get up and stand up and prepare to resist the advance of this antimicrobial resistance problem. Now, there are many interventions that can be done on the ground for your antimicrobial stewardship program. One study said that of the 23 interventions that have been posited, perhaps only about 5 of them have really stood the test. I'm not sure how much, how seriously to take that. I have to take the study because they shared how they did it and what was done. I don't know if any of our other speakers would comment on that later on. Because, for example, antibiotic cycling is not something that is touted a lot, but in our local setting, we have used antibiotic cycling with good effect. And for those who may not be aware of what this is, we might see a lot of gentamicin resistance coming back from a unit. And when we compare the usage, we can see when the resistance started to go up, when the usage, and compare it with when the usage started to increase. And the truth is we will now stop, give an antibiotic holiday, no more gentamicin for a period of time, whether it's 3 months or 6 months. And then after that, during that period, the gentamicin resistance goes back down. Now, I understand it's like squeezing the balloon, but sometimes when you're desperate, even squeezing the balloon will help, especially when you may not have some of the newer antibiotics that are available elsewhere. So the 5 interventions that stood the test are pre-authorization, so use of selected antibiotics requiring approval from a stewardship team member. A consultant microbiologist and ID physician might have to countersign a prescription before you can take it to the pharmacy, or a prospective audit with feedback where you send a prescription and there's review of antibiotic regimens in real time and recommendations are made. There's implementation of interventions that reduce the use of antibiotics with high risk of Clostridium difficile associated diarrhea. Shortest effective duration of antibiotics, see how you can do that as opposed to keeping the patients on antibiotics for much longer than they need to be. Implementation of pharmacokinetic monitoring with dose adjustment for agents like your aminoglycosides, gentamicin, amikacin. And this one has your IV to PO switch, which we have started to do. I'm not sure how consistent we are, but we have our form, or IV to PO conversion order form. The pharmacist is supposed to be helping us to draw this to the attention of the attending physician. Might be the pharmacist will say, I think this patient qualifies. Do you agree? Can you just review this patient's notes and see if we can now switch? And just to say that this saves money as well. When you look at something like a quinolone, like ciprofloxacin, for example, a pharmacist, I'm reliably informed by the pharmacist that an oral, for the oral Cipro, that would be like $100 and something, whereas a parenteral would be 13,000. So you're looking at using a drug that will cost you 13,000 when the oral would cost 100. And bioavailability is almost the same and you just need to switch after a relatively short period of time, switch from the parenteral to the oral to finish the course, as long as the patient qualifies for that switch. And we give some reasons that would make the patient not qualify. So we recognize the threat levels of different organisms and we're monitoring them in the lab. You have your urgent level. So these are your high consequence antibiotic resistant threats because of significant risks identified across several criteria. You have Clostridium difficile, carbapenem resistant Enterobacteriaceae. Can I just tell you right here now that our level of carbapenem resistant Enterobacteriaceae is extremely high. There was a time when our ESBLs, or extended spectrum beta-lactamase producing organisms like E. coli, Klebsiella pneumonia, Enterobacter, we were worried about them. No, they're common. We don't worry about them as much anymore. We've now gone to worry about our carbapenem resistant Enterobacteriaceae. What do we do when we have this popping up? But a study was done recently and we found we did have a higher level of CREs than we had expected to find. And then there's another set of organisms that would represent the serious level, and then another set that would represent the concerning level. In the interest of time, I'm not going to go into all of these. I'm going to just move on. And I'm just going to say, I'm coming down, I'll soon be finished, to say that we found a patient with this organism, Burkholderia cepacia, in the urine, a female patient in her 40s, resistant to 21 of 22 antibiotics tested against it. And yes, some of these antibiotics would not normally work against Burkholderia, but we were that frustrated that we want to try everything we had in the book just in case. So when you see an organism like this, you see it concentrates your mind wonderfully, and you realize that the problem that we face is not theoretical or hypothetical, it's real. We did a survey across the country just to look at some of the antibiotic prescribing practices. So we looked at persons, for example, who would treat an acute pharyngitis with fever, and this is with your physicians, okay? And so we see here that 67% would treat an acute pharyngitis with fever, just that, all right? Cough productive of yellow-green sputum, 79% of persons would treat patients who have this. And this is overall. We broke it down into hospital-based, outpatient, and equal proportion of both. But just looking at the overall result, now you understand that there are some areas that we need to tighten up on. We looked at our ESBL, extended spectrum beta-lactamase, Klebsiella pneumoniae, and in 2002, we saw that we had 17.2%. Most of them were on the pediatric ward, and our E. coli at the time was less than 1%. That was in 2002. In 2009, it moved to 4. And then much later on, we've seen 60% ESBLs, Klebsiella pneumoniae. Now, this was probably in a particular population, so I don't want to belabor it, but I just wanted to just give you a snapshot of that anyway. We have tried doing antibiograms at the hospital, at University Hospital. Our target was to do them once per year, and we did try for 2 years, then COVID came, and we must confess that we've had a setback there. But this is just to give persons who know, you have an idea here. This is overall percentage susceptibility of select gram-negative isolates from all specimens. So you have your antibiotics here, you have the name of your organism here, and then you have your percentage susceptibility here. And beside it, you have the number of organisms. So we can have an idea whether this was a representative sample or this was just a very tiny sample, and therefore we might not be able to rely on this data. And so we have this, we actually gave out some of these to our clinicians and our pharmacists as well. And hopefully once the pressure eases off, we can go back to doing this, because it does help to keep tabs on your organism. It does help our clinicians to take a look to see what are the flavors of the day in terms of antibiotics, and what can be used safely and what should be stayed away from, and why it is that we need to be very conscious when we're prescribing antibiotics or antimicrobial agents. We have to take into consideration the prevailing atmosphere and deal with it accordingly. So indeed, it's a One Health approach, the collaborative effort of multiple disciplines working locally, nationally, globally to attain optimal health for people, animals, and the environment. And that is a technical definition, but based on what I've just said, you understand that we need a number of persons on board in our antimicrobial stewardship programs if we're going to succeed, if we're going to have people buy in because they understand where we're coming from, they understand the challenges, and they know why it's important. It has been said that the development of new antibiotics without having mechanisms to ensure their appropriate use, and we can extend that to say new antimicrobials, without having mechanisms to ensure their appropriate use, is like supplying your alcoholic patients with a finer brandy. And with that, I thank you very much for this opportunity to present these findings to you.
Thank you so very much, Dr. Nicholson. Wow. Antimicrobial stewardship, that sophisticated machinery made up of many moving parts, with each one designed to complement the other for maximal effect in the deterrence of antimicrobial resistance. What a wonderful presentation, very informative, a lot said in a short time. And we do know that as part of the One Health approach, we need all hands on deck. Yes? Are you a part of the moving part? Wherever it is that you fall, ensure that you can get your hospital leadership commitment, accountability, put things into action, rely on the expertise of your pharmacy technicians and pharmacists. And then we do know that each institution will not have the same level of expertise available, but whatever it is that you have, ensure you use it to the very best of your ability. All right, so we're coming on down nicely. And so remember to type your questions so we can have them at the end. But thank you so very much, Dr. Nicholson, for an excellent presentation. Now we're going to change gear a little bit. And our fourth speaker, Dr. Marisa Keppel from the Food and Agriculture Organization. She will speak on stewardship and livestock. So yes, we're changing gears a bit. Remember, we're talking about the One Health approach. So Dr. Marisa Keppel currently holds the position of Food Safety and Quality Officer at the Food and Agriculture Organization of the United Nations. And this is based in Santiago, Chile. She's responsible for working on food safety issues for 33 countries in the Latin American and Caribbean region. Now, while working at FAO headquarters in Rome, she was responsible for scientific advice to the Codex Alimentarius, working specifically with the joint experts on microbiological risk assessment and food safety advice for 193 countries. In the region, she works on aspects related to risk analysis in food safety, and her experience in food safety spans more than 20 years. Since 2016, Dr. Keppel is the FAO regional focal point for antimicrobial resistance. The work in this area has been to provide technical assistance to countries to implement their national action plans dealing with antimicrobial resistance governance and legislation, also identification of antimicrobial resistance risk factors for the animal production sectors, among other issues. Her academic training is as follows: engineer in food industries from the National Agrarian University La Molina, Lima, Peru, MS Food Science, Masters in Food Science, Food Engineering focus from the University of Florida, and a PhD in Food Science for Food Microbiology and Risk Assessment from the Rutgers, the State University of New Jersey, New Brunswick. So let us welcome at this time Dr. Keppel.
Thank you very much. Good afternoon, distinguished colleagues and participants. I will share my screen and see if you can see it. Yes? Is it visible?
Yes, we can.
Thank you so much. Yes, we are changing gears. Usually when we talk about AMR stewardship, we usually think about the human health side, but there is a stewardship for the food and agricultural side. So I will speak a little bit about this today. All right, so I will give a general overview. I will just present very lightly the new FAO action plan that was launched last week on the 19th. I will talk about the FAO AMR work in the region, and finally come back to the stewardship for plant production and protection. All right, so we start. In 2010, the three tripartite organizations signed a collaboration to work on AMR, zoonotic diseases, and antimicrobial and food safety, actually, three topics. That turned into later on a commitment called the tripartite, and finally into an MOU recently signed in 2018. Working together, we've been working together for many years, and that impulse plus the global action plan plus the next group of documents put forward by the tripartite and what was called the interagency coordination group, along with donors, put forward what we have now, which is, let me take this off my screen, there it is, which is this strengthened partnership with what is called now the Tripartite Plus, which has the Food and Agriculture Organization of the United Nations, the OIE, the World Health Organization, and UNEP, the UN Environment Program. Why? Because we believe that healthy environments, healthy people, healthy animals all contribute to what we do in this world. All right, that said, we had from 2015 to 2020, there was an FAO action plan, antimicrobial resistance. As it finished in 2020, a new one was presented, and this one supports innovation and resilience in food and agriculture sectors. And its main impact is that food and agriculture sectors, dependent livelihoods and economies are made resilient to the impacts of AMR. It has 5 pillars that have to do with governance, allocation of resources, promoting responsible use to keep antimicrobials working, enabling good practices, strengthening surveillance and research, and increasing stakeholder awareness and engagement to foster change. That said, here in the region, we have been working since 2017. We have worked with 13 countries. We have unfortunately only been able to conduct one of the tools that FAO has developed. In St. Kitts, we have not had any opportunity to do more work in the Caribbean, though we do look forward to doing so in the coming biennium. There are 2 reference centers for AMR, 2 FAO reference centers, one in Ohio State University, and you're probably very familiar with Armando Hoet, who's been doing the surveillance work with AICA in the region, and the other one, Senacica, Mexico. And these 2 are very interesting because while Ohio State is an academic research department, the reference center, the Senacica labs are government labs. So they each have their own strengths, to put forward on this work that we want to do. I won't talk about the tools, but there are 4 tools that have been developed and that we are conducting in different countries. As I said, I hope to, at some point, bring these tools also to the region so that we can conduct them with the Caribbean countries. When I think about AMR, I think this picture says more than 1,000 words, and I use it continuously because I think it lets us see the exposure pathways. If you look at this picture, what we see is the pharmaceutical compounds or the antibiotics that go into humans, companion animals, and what happens? Then if they're not controlled appropriately or used appropriately, you will see them appear in waste and go into the groundwater and probably contaminate, seawater, rivers, freshwater, groundwater. You also have, as a result of intensive animal husbandry, also these animals require at some point antimicrobials. And again, the manure and the wastewater go into the ground and cause all sorts of contamination. On the other hand, you have also here, excuse me, I'm sorry, there we go. Groundwater contamination, as you see, the little red dots are like points of light that alert you to where these antimicrobials are going and where they end up. At the end, it is a cycle. If we take a look at some facts, just because this is the WOW, the World Antimicrobial Awareness Week, let's be aware. Right now, we have a population of around, 8 billion people that will rise to probably 10 billion by 2050. At the same time, we have people moving away from the farms and the country and moving into the cities. So we're getting a rise of megacities. We have, at the moment, 52% agricultural land affected by moderate to severe degradation. We have an increase, upcoming increase of 55% more water. And we have to produce more than 60% more food to feed that growing population by 2050. So this is kind of the hard facts. It kind of helps us be aware of what and where we're grounding these things. What else do we know? How much land do we use for food production? Okay, currently the Earth's surface, as you see in this figure, you have that the Earth is 71% ocean, 29% land. Of that 29%, the land surface is 71% habitable. Of that portion of habitable land, 50% is used for agriculture. And of that 50%, the agricultural land for crops is 23%. Because the other part of it, the 77%, is used for livestock and meat and dairy to sustain the growing population. So if you think about it, it's actually the land that is available for crops is very small. And then if we look at, for example, the risks, every year the World Economic Forum puts out a survey, global risk perception survey, that CEOs and leaders from government, from industry, from different parts of the world answer to this year, and puts it out in November. So next year's will come out in January, more or less, the results. If you look at this figure, you have the top global risk by likelihood for 2021. What do we see? A lot of green ones, right? The green ones are those related to environment. So the first global risk that would be most probable, because this is likelihood, extreme weather, climate action failures, environment, human environmental damage that we had not addressed, of course, infectious diseases, biodiversity loss. And if we look at the top global risk by impact for 2021, yes, infectious diseases, we were coming on the start of a second year of COVID. The climate action failure, the weapons of mass destruction as another impact, biodiversity loss, natural resource crises, human environmental damage. This is just for us to get a kind of idea of, where are we with these problems? Because it happens that sometimes, you just, flush the toilet, open the faucet, we just go on with our lives and we're not aware of the bigger picture. This is what I'm trying to do, kind of give you the bigger picture. All right. And as we go into antimicrobial use in plant production, and protection, we know that antimicrobials are introduced through the use in livestock farming and wastewater. And you can see it here in this figure, that the antibiotics are mainly released into crop production systems through manure application and wastewater irrigation. There's a very interesting OECD document on pharmaceutical residues in freshwater systems. And what you can see, as this picture clearly shows, is these antimicrobials that are given to the fish, the companion animals, and livestock go straight into the terrestrial ecosystems and freshwater systems. They also have, they also appear in the manure, in the slurry, and the biosolids. From the ag side, from the human side, of course, the wastewater treatment plants, the landfills, the households, the hospitals. From our work in the region, we have seen that some countries do not have enough control over what happens to, for example, dead animals or the slurries or the waste that occurs in the farms. There is not a lot of enforcement. The rules exist, but sometimes the enforcement is not there. And that, of course, will affect the crops. All right, from the plant protection side, the antimicrobials are introduced through pesticide application. We know that agrochemicals are used. There has been an increase of agrochemicals, including antibiotics and antifungal pesticides. And so while these pesticides are used to control plant pathogens, it may be possible that because of their use, they are making these pathogens resistant to certain antimicrobials. So there is a lot of concern, particularly the spread of resistance to medically important antibiotics and fungicides, as has been mentioned already by earlier speakers. One example is the use of triazole fungicides. It has been shown, and I put here the link to the paper. There's a May 2021 paper on triazole, and a study that was conducted in the US, and that showed that there was an increase in use of these fungicides and the relationship to the human fungal disease, to the aspergillosis, especially for those who are immunocompromised. All right, and these are the pesticides used in the agriculture sector. Then this is just the general pesticide use. It's no breakdown, it's all of them. Pesticides that are based on antimicrobials, the ones that have active chemicals, rodenticides, all sorts of pesticides, a whole group of pesticides. So what we have seen is that over the years, this is FAO documents. I'm sorry, it's for South America. I couldn't find the one with the Caribbean region, but basically what we have seen is that it's directly related to the increase. You get an increase in the production in the agriculture sector, and at the same time, it correlates to the increase in pesticides. And this is clearly seen. You can check the webpage and get the most, this one was accessed in April, and get the most current ones. But basically it makes the point of the correlation. Now, what mitigation options do we have? Well, there is a document called the International Code of Conduct on Pesticide Management. It's been available since 2014. And what it does is optimizes regulatory and technical measures required to throughout the life cycle of pesticides, and it includes the antimicrobial pesticides. The other option is to implement the global plan on antimicrobial resistance. It has a section on monitoring and evaluation of the use of antimicrobials at regional and country levels, and the document is here. I mean, you can click on it and have access to that. And then, of course, we have the international standards for phytosanitary measures to prevent the introduction of pests, to strengthen monitoring of antimicrobial resistant diseases. I've put here the link. You will see that when you click here, you will find some very recent standards that have been put forward in 2021. And these from the International Plant Protection Convention. What other mitigation options do we have? Well, IPMs, integrated pest management. Why? Because there is a need to have more environmentally friendly solutions for growing healthy crops. be it biological control, crop diversification, some agroecological practices, use of resistant crop varieties. And again, with all that, also strengthen the capacity of smallholder farmers. Because what we also see is that sometimes at the smallholder farmer level, though they don't use a lot of chemicals, sometimes it's a force of habit of what they've been used to using without knowing or being aware that it could be causing antimicrobial resistance. There are farmer field school programs that are ongoing, and they are including AMR within FAO. There is a need for reinforcement of agricultural extension services and other capacity building activities. Now, the priorities to strengthen the AMR stewardship, I've highlighted some of these in bold. The One Health approach is important. Why? Because it facilitates the regional and global dialogue to protect the health of humans, animals, and the environment. Raise awareness on AMR in plant production and protection. Sometimes there's an idea that if we cannot see it, we're not aware of it. Well, we have to raise the awareness for this, and I really thank you for inviting me to give this talk. I think it's important. Data collection. We need also to show the policymakers, the same as our former speaker, we need to show them with numbers, with knowledge, what those problems are. The AMR and AMU, antimicrobial use in plant production and protection, to support this policy and decision making. We have to also assist countries and think about agricultural legislation, regulations, policies, programs. Sometimes we don't need to have, and you probably are aware about this, there is no need to have a legislation that says AMR per se. Sometimes it's enough to just have it more explicit within your programs for best practices, for example, to have it mentioned in different levels, give it some other regulatory options. One other thing to consider is to develop country-specific and agri-food value chain-based antimicrobial use and AMR surveillance and monitoring systems. Now, these for the agriculture side, I call them new because though they're there, they've not been fully made aware of to everyone. All right. Again, laboratories. If we're going to do surveillance and we're going to do monitoring, the laboratory and the laboratory networks are important across different food and agriculture sectors. Promote the adoption of AMR relevant international standards and guidelines, and of course, application of good practices at country level. As we had already mentioned, the farmer field schools to increase the knowledge of smallholder farmers and develop capacity. At the same time, increase the accessibility and affordability of plant protection services to smallholder farmers and strengthen innovation and R&D. This is also very necessary because when we ran one of our situation analysis tools with some of the countries, some of the questions at the end of that tool were on innovation and R&D and risk communication. And the results we got, the answers were, we have R&D, we have scientists, we have academia. But the truth be said, we didn't see the linkages between that which the academics did or the research centers and what happens at the other end with the policy and decision makers. So yes, I mean, it is there, but we have to make better linkages so that it works in favor of the countries. These are some useful links and I share them with you here. I must thank Dr. Bao Gen Gu from the Pesticide Management Division at FAO headquarters and his team who have helped me out on these links and putting forward some of the material. And I believe, as far as One Health goes, I wanted to share with you, this is just one example of the linkages between human health, animal and plant health, and the negative consequences of plant health problems on public health. This is a paper from 2021, early 2021, where they had 4 case studies. They had plant pathogens, mycotoxins, human pathogens, and pesticide use. And they analyzed each one of these to see what were the linkages across, for example, What was the problem with the plant health? You know, for example, in the first case, there were pathogens, xanthomonas, which would cause wilting, rotting, plant death in bananas. What was the plant health impact? For those populations, higher crop prices, loss of stable crop, and for the impact on the persons, altered household eating practices. The same, for example, for food safety. And each of these, I will not go through all of these, but they're there for you to read. And if you're interested, here is the citation for the paper. I thought it was an interesting way of showing those linkages, because when we think of One Health, sometimes we think of only the animals and the people. Sometimes we don't make that connection totally down to the crops, the environment, the water, the soil. So just as an example. And finally, what's coming up? For a launch on January 2022, the tripartite has decided to put forward an AMR multi-stakeholder partnership platform. We are currently having some of those conversations with some of the Caribbean countries. So we hope that by January, we'll be able to give more news on this, because we do believe that a multi-stakeholder partnership will help put forward regional priorities on AMR. And I think with that, I am done. Thank you very much. Over to you.
Thank you so very much, Dr. Capel, for another insightful and informative presentation, even as we change gear to stewardship and livestock. I'm sure the audience, they have a lot of questions just waiting to post. And we're here waiting patiently too. But we do have our local representative, Dr. Osbill Watson from the Ministry of Agriculture and Fisheries. And he is our local representative, and he's the Chief Veterinary Officer for the Veterinary Services Division in the Ministry of Agriculture and Fisheries. He's online, so if you do have questions for him on stewardship and livestock, please feel free to post. Okay, so thank you so very much, Dr. Capel, for detailing stewardship and livestock. So we're at that very interesting part of the day, of the morning, where we will just take questions from the audience. But I noted in the chat that someone placed that Dr. Nicholson answered all my questions from her presentation. And so we thank you, Dr. Nicholson, for a very thorough presentation. And so at this time, we're open for questions. And while you're getting ready with yours, I will just ask, and any of the panelists could just help to respond. I know Dr. Nicholson went in detail as to the aspect. If you do not have your own infection control doctor or your medical microbiologist in your area, what are some of the things that, you know, our outpatient clinicians can do to just ensure that antimicrobial stewardship is adhered to? So I don't know who wants to take that one. I know Dr. Nicholson went in detail, but just for recap, you know, persons can benefit. Do we have Dr. Shaw who maybe could help? I'm not sure. Dr. Nick, we're not hearing if your mic is open. Your mic is open, but we're not hearing.
No, I was asked to unmute by the host. I'm sorry.
Okay, right. So I was just asking for persons, either yourself or Dr. Shaw, but you went in detail, but just for emphasis, what are some of the things that our outpatient doctors can do? So we know we may not have all the necessary personnel similarly to other hospitals who do not have, the infection control doctor, the medical microbiologist. Just some tips quickly, what are some of the things our outpatient clinicians can do to ensure they have appropriate antimicrobial stewardship being adhered to?
Well, just off the top of my head, Dr. Nelson, I would say that if there could be found a man among them or a woman among them, if there could be found somebody with a special interest to light the fire, that could get things going. Usually it takes somebody with a keen interest to start things going. And then the idea would be to keep an eye, some kind of surveillance, read the antimicrobial resistance patterns that they're getting back. Of course, that would mean that they have lab service. So assuming that they do, then they can begin to track the antimicrobial resistance patterns that they're seeing, identify, perhaps work with somebody from the hospital setting if necessary, or somebody whom they could identify as a kind of mentor until this gets going. We know that there may not be a lot of it out there in the outpatient setting for obvious reasons, overcrowding, trying to get through the numbers, etc. But it's so important if somebody could step back and take it on and then try to recruit other persons of like mind. And then start small in terms of monitoring your resistance patterns, seeing if there's anything that catches the eye that requires special attention, take it from there, and then view the literature. We talked about a lot of aid that's available in the literature. Sometimes you need aid with skin on, aid with flesh on, with clothes on. So if there's somebody in your region who has that kind of passion, maybe you could link with that person and allow the outpatient department to become like an area that is monitored by the hospital setting in conjunction with somebody who is out there and who is aware of all the challenges. We could go on and on, but I'll stop there.
Yeah, thank you so very much, Dr. Nichols. You did share some of that, but thank you so much for repeating and as well as just giving insight to that aspect. Thank you so very much. Dr. Pilar, I'm thinking you could help us just for persons who they're working in a resource limited setting. You shared a bit on infection prevention and control and the importance, of having that, in a detailed manner and adherence to it. So how can persons with limited resources ensure that their infection prevention and control is really up to standard? What are some of the things that they can do?
Absolutely. I think that infection prevention and control is one of the key measures to contain AMR. And of course, we know that for multi-drug resistant organisms, such like Xylella or Acinetobacter or others, in addition to standard precaution, we need to implement contact precaution, which in some limited resource setting is really hard. It's really difficult to find the place to cohort, to isolate the patients, to provide the PPE, the personal protective equipment for the staff. So this is a challenge, and it's something that should be discussed internally in the healthcare settings. But we always recommend to start with the basic, start with the standard precaution. Standard precautions should be implemented no matter what. And it is possible to implement this precaution in every setting across the globe. So this is the basic, and that as well will prevent the dissemination of outbreak. For effective infection prevention and control practice, you will need as well microbiology labs. So the microbiology lab will advise about the pathogen and as well about the potential mechanism of transmission. So as well, this kind of interaction and collaboration in the hospitals, it is much better if we have a hospital community committee, healthcare associated infection prevention and control committee, where the discussions will happen in a multidisciplinary way with microbiologists and as well infection prevention and control epidemiologists, and as well the pharmacy, because as well part of now we have more and more evidence about the importance of integrate antimicrobial stewardship in infection prevention and control practice. So sorry for the long response, but that is...
No, excellent. This is what we want. Thank you so very much. Very detailed. Thank you so much, Dr. Pilar. And I'm thinking that we could take one. Dr. Capel had to leave. And so I don't know if Dr. Watson, he wants to just share, greet us briefly and just give the vets among us, or the clinicians who have to deal with our precious species of the animals, share anything with us just before we take one or two more questions. Dr. Watson?
Are you hear me?
Yes, we can.
All right, thank you. Thanks for having me. And I must say, we at the Ministry of Agriculture and Fisheries are very impressed with the activities so far in relation to Antimicrobial Awareness Week. We are cognizant of the fact that every sector of our society has some impact on all that we do in relation to the use of antimicrobials. And so our veterinarians, both in private practice and in government, are fully aware and fully on board as it relates to the whole aspect of prudent use of antimicrobials. It has been a challenge in relation to treating some animals and the whole aspect of resistance in a few cases. But veterinarians have gotten over by trying to adopt new ways of satisfying their clients in terms of getting around, trying to find new antimicrobials where they exist. And one very important thing that we note is that as it relates to the critical list of antibiotics in particular, that our veterinarians are very cognizant of the fact that they spare antibiotics which are known to be precious, especially for use by our colleagues in the medical profession, so that they will have those for use, and they will only be used in veterinary medicine where there is an absolute necessity. And so we are also working with our farmers, and in relation to the prevention of use of antimicrobials, we are looking at the things that we should be doing in terms of hygiene, sanitation, vaccination programs, adequate nutritional programs. So to strengthen the actual immune system of the animal, and to be able to cope with the environmental conditions. Of course, the actual issues of global warming, climate change, etc., would have put additional stress on animals as they try to survive. But we, as veterinarians and in the veterinary profession, are working with farmers to be able to boost the ability of our animals and our pets to be able to meet the challenges, vitamins especially, and balanced nutrition where necessary, and as I indicated, vaccines where necessary, to be able to keep these animals healthy, and by extension to safeguard human health. So we are fully on board at the Ministry of Agriculture and Fisheries, and we will be working together. The saying is that we are all in this thing together, and we are in it for the long haul. So thank you very much for having us.
Okay, thank you so very much, Dr. Watson. And it has been my distinguished pleasure just to serve with you this morning as we shared in Antimicrobial Awareness as a part of Antimicrobial Awareness Week. As you know, one of the key objectives that they had was to improve awareness and understanding of antimicrobial resistance through effective communication, education, and training. And we really did have a treat from all our presenters this morning. Also, the objective that they had was to ensure that generations to come would continue to prevent and treat infectious diseases with the effective medicines. And so I'd like to just use this opportunity to thank you for having me. Thank you, Dr. Pilar Ramon Pardo from the Pan American Health Organization, who she took us so clearly through what is antimicrobial stewardship, and she shared some of PAHO's initiatives and the future plans that they had for antimicrobial stewardship and its implementation in various sectors. And we have from our own Ministry of Health and Wellness, Dr. Karen Shaw, who went to the history of antimicrobial resistance and went through the antibiotic pipelines. And as someone shared in the chat, Dr. Alison Nichols answered all her questions as she spoke on preserving antimicrobials by stewardship, implementation of antimicrobial stewardship in human health. Dr. Capo had to leave us, but we want to also thank her as she shared on stewardship and livestock on behalf of the Food and Agriculture Organization. And you just heard our own local representative, Dr. Osbill Watson from the Ministry of Agriculture and Fisheries. All our speakers this morning, into this afternoon, they shared on the One Health approach, and that it is the excellent and probably the only way to combat antimicrobial resistance. And so again, we applaud the efforts of the Pan American Health Organization, the Ministry of Health and Wellness, the Ministry of Agriculture and Fisheries, the Ministry of Industry, Investment and Commerce, and of course, University of the West Indies for this collaboration. Dr. Glenn Reynolds Campbell is on with us, and Dr. Kidd, we just want to say thank you for joining in with us and have a wonderful day.